Welcome everybody to today's webinar. Just going to give it a couple moments to allow people to connect. So while people are connecting, I'll take a moment to introduce myself. My name is Rosemary Morgan. I am an associate scientist at the Johns Hopkins Bloomberg School of Public Health. I am also a member of the RelabHS consortium, which is hosting today's webinar, which is titled Rehabilitation Through a Gender Lens. So before we get going into the main content of today's webinar, a little bit of housekeeping. So the webinar today is being recorded, and the recording will be made available to everyone who registered and will be hosted on the RelabHS website. Participants are invited to keep their camera and microphone off, or we please ask you to keep your camera and microphone off during today's webinar. And sign language interpretation is available today. So in order to access the sign language interpretation, we have three excellent interpreters. We have Ramon Wolf, Adam McCormick, and Susan Emerson. And in order to view them, you need to find them in the list of participants. And make sure they will be keeping their video off. So what you want to do is when you're viewing, you want to have it in the grid format. So at the very top, you'll see a button, be able to view the screen. You want to click on everyone. And then each of these, the interpreter that is interpreting at that moment will have their video on. So please do, and if you have, please do check that out. If you're having any trouble to finding them, please let us know in the chat box. So closed captioning is available today in English. The subtitles are not embedded, but can be viewed on a streaming platform, and the link will be placed in the chat box now. So please, whoever is posting that link, please post it in the chat box now. And we will have time for questions during today's webinar. Please feel free to ask your questions at any time in the chat box, and these will be addressed in the Q&A session or answered in writing. So here is the agenda for today's webinar. I'm going to start with a quick introduction to why we're here today. Then our part one is titled Leveraging the Voices of Rehabilitation Users. We're going to hear directly from a few rehabilitation video users, both in person and through video. Part two is titled Addressing Challenges and Implementing Recommendations. We have an excellent lineup of panelists today who will be looking and talking about key recommendations about integrating a gender lens into rehabilitation. Then we're going to end with a Q&A session and closing remarks. So today's webinar draws on a recently released fact sheet by RelabHS. And please, if someone could provide the link for that fact sheet in the chat box, please do so now. So this fact sheet is based on evidence from a scoping review, which yielded 65 research articles and editorials. So the fact sheet provides key facts on how gender shapes access, use, and adherence to rehabilitation, examples of successful approaches to integrating gender into rehabilitation, and recommendations to health decision makers on what is needed to move toward a more gender responsive rehabilitation approach within health systems. So what are some of the unmet needs of rehabilitation? So the unmet needs are, and how are these unmet needs marked by significant gender inequities? Of course, the fact sheet really outlines all of this, but here's just some basic information so to really show why we are here today. So there's an estimated 2.4 billion people who are in need of rehabilitation services, and more than 50% of them cannot access rehabilitation. so 50% unmet need. And we know that gender shapes access, use, adherence, and outcomes to rehabilitation services, and that women are less likely to be able to access rehabilitation, and when they actually do access it, are more likely to experience poorer outcomes. And in low and middle income country settings, women and girls are less likely to have access to assisted technologies. And that data and research documenting, I think my screen may have, I'm not sure if people can still see my screen.
Very sorry, Rosemary, it was not working, so I've put it myself, okay? I'm the one sharing.
Oh, okay, you weren't seeing my screen. Okay, no problem. Do you want me to go back and start again?
No, keep going, no worries. Just tell me when I need to move slides.
Okay, so in low and middle income countries, women and girls are less likely to have access to assistive technologies, and that data and research documenting and analyzing sexual and gender minorities' access to rehabilitation are very scarce. So not only do we see a gap in data looking at gender differences for between men and women, but it's even bigger gap when we're looking at sexual and gender minorities. And rehabilitation is not sufficiently integrated in health systems, and it is rare to find gender responsive planning and service delivery. However, some good examples do exist and should serve and do serve as an inspiration. Next slide, please. Can you move? Yeah, thank you. So what are some of the gender barriers that exist across key dimensions of rehabilitation services? Well, we have availability, accessibility, affordability, and acceptability. So in relation to availability, we know that rehabilitation has not been prioritized in health more broadly, and that there's an overall shortage of services, particularly in low and middle income countries. We know that there is a massive deficit of trained rehabilitation workforce and limited facilities, and an overall lack of availability to quality assistive devices, such as things like hearing aids, prosthetics, for people in low and middle income countries. And that there exists a persisting gender bias, which can affect decision-making over what services are offered and funded, thus limiting the availability of rehabilitation services required by women and girls. So when we're already seeing a shortage of services, the question is who gets access to those services, who gets prioritized. So in relation to accessibility, there is a tendency for services to be concentrated in urban areas, and that there's limited access to households' financial resources, safety concerns, social norms, and family obligations. These can all significantly hinder the possibility for women to travel to seek rehabilitation services. We also see discrimination in attitudes held by staff and wider society, which can affect access to rehabilitation and referrals. And regarding information accessibility, the evidence shows that women often receive less comprehensive inpatient education than men. And moving on to affordability, we know that rehabilitation and assistive technology can represent an extremely high out-of-pocket expense, and that women have a higher likelihood of having a lower socioeconomic standing or not having insurance, which can be a significant barrier in women's decision to participate in rehabilitation. And that women with disabilities in particular are even more likely to face these barriers. And there's very strong evidence that disability and poverty are strongly interlinked. And lastly, acceptability. Services are often delivered without accounting for diverse needs of men and women and sexual and gender minorities. For example, in some cases, providers don't believe the level of pain or consider women's pain as requiring specialized pain rehabilitation. And the shortage of women personnel, health personnel, and the fact that many women report services or equipment that are not adapted to their needs may feel intimidating to women and discourage attendance. So as you can see, there are many gendered barriers which exist across these key dimensions of rehabilitation services. Next slide, please. So as we mentioned, we are part of RelabHS. RelabHS strives to increase rehabilitation services within health systems worldwide, but with a particular focus in low and middle income countries. And taking a gender equality and social inclusion lens is very much a part of this. And here you can see on the screen the partners that are a part of RelabHS. So we are a consortium of 6 partners. Next slide, please. Let's move on to part 1 of our agenda today. So which is leveraging the voices of rehabilitation users. And I am delighted to be able to introduce our panelists. We have, our panelists today, we have Smitha Sadasivan and Mariana Solarte Caicedo, who are here today. And then we also have 2 video testimonials today. So Smitha is a self-advocate and member of the advisory group of the Civil Society Engagement Mechanism for UHC 2030. And Mariana is a psychologist, activist, and rehabilitation user. For our video, after we hear from both Smitha and Mariana, we'll go directly into our video testimonies. We have Inde from Senegal, who's an advocate for women with disabilities and an AT user, and Joyce from South Sudan, who's a representative of an organization of persons with disabilities and AT users. And one thing that we would like to do today is when people introduce themselves, so Smitha and Mariana, before you start speaking, please take a moment to introduce yourselves and let our audience know where you're based, where you're sitting, what you're wearing. So for me, as I introduce myself as Rosemary, I'm currently sitting in my home office in Baltimore. I am wearing a green sweater, I have glasses, and I have my hair down today. So Smitha, I will hand it over to you.
Thank you very much, Rosemary. I am Smitha Sadasivan from India. I am a self-advocate with multiple sclerosis, and I also advocate for other rehabilitation users. I am sitting in Chennai right now at my home, and I am wearing a red kurta, and I have a very short hair. Thank you very much for guiding me towards this introduction. And yeah, so as a rehabilitation user and a woman with disability myself, I would like to give some examples from my life and fellow rehabilitation users. First is I'm a regular user of physiotherapy, whereas I have to wait for a long gap until my NGO assigns a female therapist for me. And being a woman, I always choose my therapist to be female, to be a woman therapist, whether it is any alternative therapy for that matter, whether it is CST, counseling, or anything else, or even vision therapy. And it has been 2 years now since I have gone into the vision therapy clinic because of the pandemic and also the lack of caregiver service, as my mom is my companion all the time whenever I visit a therapy center or or a hospital. So for women, it is again an issue of caregivers, which is mostly our own parents, our own mothers or sisters. And so we have naturally less options and lesser choices when compared to men with disabilities because of the cultural context, the social stigma, and also the inaccessibility that we face. For example, if we have to access a rehabilitation service which is not usually provided at our own homes, then we have to approach the district headquarter hospitals or rehabilitation centers, which is always an inaccessible building, and the transport is inaccessible, the caregiver support is not available, and the toilets basically are
Smitha, I think we might have lost you.
no. I'm here. Sorry.
Okay, please continue.
Hello. Yeah. So, so that is my yeah. So that is how we are getting delayed services, which again leads to denial of services. And there are again lack of specialized services like bladder bowel management or home-based catheterization service, bed sore management or menstrual management for people with women with severe disabilities. Even the urine bottles are not designed to the use of women with disabilities or any assistive technology for that matter. It is not available for women with disabilities is one thing, and it is not designed for all genders, whether women with disabilities or people belonging to third gender, and it is not suiting the biological physique of women with disabilities or the third gender. And on top of everything is inaccessible information and communication on rehabilitation services. Government is coming up with different programs, whereas I am not able to access it. Government says in the news I get to see that the service will come to my doorstep, but nobody is coming to my doorstep, and I am not getting any further information whom to approach or where to get the service. And when I inquire the health department, I am not getting any more referrals. So this is the kind of situation that women with disabilities are in. When compared to me, when I myself, who is much informed than other women with disabilities, face such issues, we can think of women with disabilities in rural areas, in poverty, in an illiterate background. So it is multiple marginalization that they face. And I would like to give a last instance about spinal cord injury people. Like we all know that after spinal cord injury, people will be given medical intervention and then they are sent home with rehabilitation suggestions. Whereas women with spinal cord injury in India, there are many cases where women with spinal cord injury die, and it is their families themselves which let them die. It is not directly they are killing them, but they are just they are dying because of ignorance and neglect and lack of care. So the families think women with disabilities are burden, and in many places, natural death happens because of lack of care. And so it is very, very important that there is community based rehabilitation available for women with disabilities, and more investment should be done by the government with regard to rehabilitation, and rehabilitation should be considered under UHC as well. UHC policies mention that, UHC Millennium, the goals are saying that, but it is not being implemented. And we need more women and third gender professionals in rehabilitation work. We have to engage women with disabilities and representative organizations in discussions, decisions, planning, and execution. And there should be disaggregated data of women and third gender persons with disabilities made available by the government. So we need all these things for sure, which is also recommended by the fact sheet. But why? Why do we need all these things? Because rehabilitation is the premise on which capacities are developed. Whether whether my education or employability or leisure or my independent living, it is based on my capacity, which is developed only by my rehabilitation. And so rehabilitation is crucial for women with disabilities, and women with disabilities continue to be stigmatized on an assumed incapacity till date. So we definitely need accessible, affordable, and gender-based rehabilitation, and it is a non-negotiable. Thank you very much.
Thank you so much, Smitha, for that really, really impassioned description of your experiences and your recommendations. Now we're going to move on and hear from Mariana from Colombia. Mariana, the floor is yours.
Thank you. Hi, everyone. I would like to thank you all for being here and for listening to my story. It might be a little bit mixed up, as I'm a psychologist who works with disability since my first year of university, and I'm also a rehabilitation user thanks to my arthritis, fibromyalgia, depression, and anxiety. I'm wearing a green t-shirt, some glasses, and I'm sitting in my brother's bedroom because his desk is the most comfortable all around the house. I wrote something and I would like to share it with all of you. During the past 2 years, immunocompromised and disabled people all around the world have had their own pandemic waves, specific moments in which we are all having to remind the world that our lives are valid, worth it, and important. We've seen how people all around the world have been united under the premise that we all have to take care of us for others, that we have a shared responsibility towards our neighbor, no matter their age, race, gender, pre-existing condition, nationalities, disabilities, etc., in order to protect them while taking all the necessary measures for all of us. That beautiful in paper feeling has shown several loopholes in practice, but I want to focus on those regarding disability. Every far too often, someone comes out and says something like in the line of, well, it's going great. The pandemic is only affecting those with pre-existing conditions or disabilities, but we should go back to normal because we are pretty much there anyways. How on earth is it normal when it's killing a segment of people who represents the 15% of the total world population, according to the World Health Organization? How on earth it is normal that every speech comes with an ableist underlying that leaves every single person with a disability or pre-existing condition or immunosuppression thinking, how are we going to justify our existence? Conditions are far from optimal, but people with disabilities have come a long way in matters of human rights and recognitions and equity in certain limited spaces, which has been unfortunately reversed thanks to the pandemic. I'll tell you my story. I had COVID in the beginning of the pandemic, April 2020 to be more precise. I started hearing a lot of stories of people who, like me, immunosuppressed and with 3 pre-existing conditions and a disability, were the perfect case to die as a result of this new virus. So I secluded in my house. I stopped seeing my father, my psychologist, my psychiatrist, my rheumatologist, my friends, and my rehabilitation team with whom I have made certain progress in keeping my hands somehow functional. A month later, I was hospitalized with COVID. I had to suspend my arthritis medication, and in a combination of lack of medicine, long COVID, and side effects, my whole right side, which was good until that moment, started losing strength, capacity, mobility, and ability. I was without medication and without even telemedicine consultation with my doctor for 3 months. The damage that was done is still done until today. It's not reversible. I couldn't go to the doctor in almost a year, so I was left with telemedicine, which in some cases, like psychotherapy, I appreciate. But how do you explain the progress of disability through WhatsApp? I'm not a doctor, and I don't pretend to be, so while all I could say was, well, I can move this joint as I used to, and I see it kind of purple or reddish. I can't help but wonder if we'd be better if we wouldn't have taken all the time that pandemic stole from us. Has anyone stopped and realized that we, people with disabilities, are sacrificing, or how much have we lost mentally, physically, socially, and emotionally? Have we ever thought that some of us, or many of us, are not in the possibility to have just a cold and we can afford to catch it? Have we understood that this pandemic is making us choose between studying, going to school, having a job, social connections, leisure time, or being safe? I was a rehabilitation user in 2 times. First, when I was 19 years old, I went to Pullman, respiratory rehabilitation. I went there and a nurse had a sheet with the same indications no matter my gender or my occupation, which I found it weird. I sat down in a room with 8 others. They were all men over 70 years old. No one talked to me. They talked about each other, about politics, and about economy, and about death. There was even a former Colombian president there. I couldn't help but feel lost as a 19-year-old while listening to my peers talking about how healthy they were and how life has passed them by. It's safe to say I never went back. I have the same experience when I went back to rehabilitation for arthritis for 2 months before the pandemic. All I could find were kids that had problems in school and adults over 80. And every single person that was supposed to work with me would look at me with pity eyes and tell me, "You are so young. Why aren't you taking advantage of your life?" I want to be able to open my door with my keys. I want to dress up without help. I want to carry groceries without everything falling apart. I want to go on a first date with a walking cane. I want to have fulfilling sex life that doesn't leave me recovering for a week. I want to feel that I can hold a baby or my cat without the imminent feeling of my whole upper body shaking and fear of falling. I want to travel with my friends without thinking, will this place will be accessible? Or will I be able to travel with them knowing that I'm constantly drained and having a lot of medication? And if I ever need a wheelchair in the travel, will some of them will carry me, or do I have the money to rent one of those electrical ones? And I know rehabilitation won't fix all of that, but I wish there was a place in which I, a disabled 27-year-old, could feel it there and express her fears. I want to have options. I don't want shocked faces when I say I want to be a mom someday, or the typical questions of, but you will have some help. You know that? I don't want to have to quit the possibility of being a mom right now because the medication I take makes every pregnancy that I may have unviable. I want to have walking canes that I can use while wearing my purse. And in that matter, I want purses that don't hurt every joint I have. I don't want any more pity when I express how hard it is to be a woman that is caregiving, caring, dependable, full of details, and a psychologist, and a person who struggles with psychosocial and physical disabilities herself. Nor I want admiration. I want a system in which I can be all of those things and everything I want to be. Thank you.
Thank you so much, Mariana. Thank you for your vulnerability and for sharing your story with us today. We're now going to move on to our video testimonials now. We'll be hearing from Ende from Senegal and Joyce from South Sudan.
Can't hear. Audio not working.
Can you restart the video, please, from the beginning? And it doesn't, that we can't seem to hear the audio. We still can't hear the audio, so whoever's showing it on their computer, can you please turn the audio up on your computer? I can see it here, it's there, but I don't think it's loud enough. Even louder, please.
Bonjour, je suis Madame Diéné, présidente du comité des femmes de la Fédération sénégalaise des associations de personnes handicapées. J'ai eu la poliomyélite à l'âge d'1 an et je marche à l'aide d'un appareil orthopédique et aussi à l'aide de 2 cannes anglaises. Par rapport à mes soins de réadaptation et mes aides techniques, quand j'étais jeune, tout cela a été pris en charge par mon père. Donc, c'est lui qui paye.
I'm afraid we can't see the subtitles, so not only can we not read what's going on, but our sign language interpreters cannot interpret it. We can see it then, so if you can just hover your mouse over it, I think keep your mouse moving, we'll be able to see what's going on.
Donc, par rapport à mon appareil orthopédique, c'est là où j'ai des difficultés. Parce que le type d'appareil que je porte n'est plus fabriqué au Sénégal. Donc, les nouveaux appareils ne me conviennent pas, sincèrement. Donc, je suis obligée de réparer à chaque fois mon ancien appareil, ou bien ce sont les techniciens orthopédistes qui, avec les appareils de seconde main qui reçoivent de la France, qui essaient de les adapter pour permettre vraiment ma mobilité. Donc, c'est dire que par rapport à l'appareil orthopédique, c'est déjà un moyen. Donc, par rapport à la prise en compte du genre et de la réadaptation, c'est une question assez intéressante. Parce que moi, personnellement, par rapport à mon choix, je porte un appareil qui commence à partir des pieds jusqu'à la hanche. Il faut dire que par rapport aux consultations même orthopédiques, moi j'aurais préféré avoir une femme, une technicienne qui puisse me consulter. Donc ça, c'est mon choix par rapport à cette question assez intime, parce qu'il faut dire que c'est des pieds à la hanche. Donc, moi, c'est mon choix. J'aurais préféré, en matière de réadaptation, d'avoir une technicienne qui puisse m'accompagner dans ce sens. Par rapport à mes autres sœurs handicapées aussi, je sais que sur le plan des aides techniques, surtout par rapport à la chaise roulante, certaines ont un bébé, un petit enfant. Donc, ils ont besoin quand même d'avoir une chaise assez large pour vraiment leur permettre de porter leur enfant. Donc, là aussi, il est important de prendre en compte ces besoins spécifiques des femmes handicapées, de les adapter par rapport à leur aide technique. Merci.
Great. We will now hear from Joyce from South Sudan.
Thank you so much. My name is Joyce Dikun Charles from South Sudan Women with Disabilities Network. So I'm so happy to be in this video interview. What I wanted to say is that the chances of women or women and girls with disabilities access to rehabilitation has been reduced because sometimes there's no access to information. Women are not getting information. This is number one, and also no access to computers. Sometimes they miss information because the world of today technology. So it's difficult for women with disabilities to get access to information. This is number one, and number two also. Sometimes women are marginalized, especially women with disabilities. They are the most marginalized group. You will find that in the family, a girl with disabilities will not send to school. They will not take care of that child with disabilities or girl with disability because of her disability. So the family have negative attitudes. It's also contribute to that, and also sometimes, you know, our cultures also contribute to these challenges. So these are some of the challenges that ladies with disabilities are facing. So also you will find that at home, women with disabilities, they are busy also. They are busy with taking care of the children at home. You know, sometimes there's no time to go to DPOs, so it's a big challenge also for them. So they are not able to get the assistive devices. And people also, they are not aware about the assistive devices. This is also one of the challenge. So, and also getting the assistive devices is a big challenge because we don't have them here in our country. And they used to bring it from abroad. Also, it's a big challenge. And to bring it from another country, it needs a lot of money. So people with disabilities or women with disabilities cannot afford to buy. So it's a big challenge for us as women with disabilities.
Great, thank you. They're not here with us today, but our thanks to Ende and Joyce. So now we'd like to move on to the second part of our webinar today. So if you can, please share the slides. So in part two, we'll be looking at addressing challenges and implementing recommendations. So these are our panelists today. We have Angelo Nakafeero, who's the Commissioner of Gender and Women Affairs in Uganda. Ghulam Nizamani, the General Director at the Department of Empowerment of Persons with Disabilities in Pakistan. Lillian Aswanwe, the Gender and Social Inclusion Officer for RelabHS in Uganda. Sabina Kikone, the Technical Unit Manager at Humanity Inclusion in Myanmar. And then we'll also have a video from Gertrude Fefe Ame, who's a member of the UN Committee on the Convention of the Rights of Persons with Disabilities, the Global Advisor Manager for Social Inclusion at Sightsavers, and member of the board of the Ghana Federation of Disability Organizations. So before, what we'd like to do is ask each of the panelists to reflect on the recommendations that are in the fact sheet. We would like each panelist to talk about which is the recommendation that they find most relevant in their context based on their experience and why, and what should be done to translate this recommendation into action and reality. So next slide, please. So for those of you who may not have had a chance to see the recommendations, here they are in a nutshell. So we have strengthen and integrate rehabilitation in health systems. So this includes efforts in investing in gender inclusive and gender responsive rehabilitation workforce and in applying alternative solutions that cater for the needs of diverse users, including via alternative solutions like mobile clinics, home-based care, and tele-rehabilitation. So really gender responsive health workforce service delivery in relation to rehabilitation. Next, we have incorporate rehabilitation and assistive technology into universal health coverage schemes and take specific actions to increase and monitor coverage across genders with attention to women, girls, and marginalized groups. Next, we have ensure the meaningful participation of concerned people of all genders and persons with disabilities throughout all rehabilitation planning and delivery. And finally, we have at the bottom there, enhance research on gender dimensions of rehabilitation and collect disaggregated data, and build demand for rehabilitation services and assistive technology across people of all genders, including via specific awareness raising on the positive impact of rehabilitation and providing opportunities for people of all genders to be seen and included. So without further ado, I'd like to move us to our panelists to each reflect on those recommendations of which recommendation they find most relevant in their context and based on their experience, and how can we translate that recommendation into action and reality. So Angela, Angela Nakafeero, I'd like to hand it over to you to get us started.
Thank you very much, Rosemary. First of all, thank you for your kind introduction. I would like to thank the entire team that has undertaken this important piece of work. It's really timely because it really presents very interesting insights in what we need to take into account when we talk about rehabilitation services and assistive technology. From my point of view, I find recommendation 3 on strengthening rehabilitation services and assistive technology within the health system very, very important, because it's about really integrating these services into the entire system. And I also want to add an addition to that, because it's not only the health system, but it's the entire government spectrum. Because even if I have a wheelchair and I'm not able to access nice roads where I can use my wheelchair, I will not be able to be mobile. The same applies to classrooms. If the learner comes in with a wheelchair without a ramp, she may not be able to access. So we need to think about the entire government spectrum, of course, health service delivery being very, very important. The same recommendation also captures quite a number of issues to do with accessibility, issues to do with affordability. I know our colleague from South Sudan has talked about the unavailability of these technologies and services. So it requires that the entire government makes the right investments in terms of ensuring that the environment is enabling and the services are available within the system. I would also like to talk about the few challenges that I see in the implementation of the recommendations. First and foremost, also bearing in mind what my sister from South Sudan has emphasized, is the issue of patriarchy. As women, we in most cases give priority to our husbands and sons, and we fail to look after ourselves. We do the care role of others, not caring for ourselves. So we need to change the paradigm of ensuring that women and girls look at themselves as equal human beings and are able to prioritize their needs and interests. The kind of investment I've already talked about, it is very, very important, cutting across the entire government spectrum. In terms of what we need to do right, it's about evidence-based investments across the entire spectrum. It's very, very important, such that we are looking at the entire planning and budgeting process in our countries, and we're able to articulate and identify these services that are required and be able to plan and allocate resources for them. It also requires that we also need to invest into long-term prevention of some of these disabilities. Ladies and gentlemen, we all know that if babies are vaccinated, then polio is not going to be an issue. If we take care of our babies when they are still young in terms of nutrition, we may not see them being retarded, such that the development of the brain is undermined. So we really need to also go ahead and look at the long-term investments in terms of prevention of some of disabilities that come along the way. The same applies in terms of preventing accidents. In Uganda, we really have a very big issue of accidents. You'll find that most of the disabled people, physical disabilities, are mainly caused by the road accidents and other forms of accidents. So if we are able to strengthen our systems and prevent some of these unfortunate circumstances, then we'll be even reducing on the demand for the technologies that are required for our sisters and brothers to really benefit and participate in life as equal human beings. The last one also builds on what my sister Jennifer has contributed, the issue of male dominancy And of course, where we need men in power to look at women as equal human beings and protect women's and girls' human rights. These are very, very important in all areas that we're discussing. Thank you very much, Rosemary. I think I've utilized my 5 minutes.
Thank you so much for that. Those really, really great words. Yeah, and moving on to our next panelist, who is Ghulam Nizamani from Pakistan. Ghulam, the floor is yours.
Thank you very much for giving me a chance. And I am here with you all. Basically, my designation is Director General of Sindh Persons with Disabilities Protection Authority. I am working since long as a person with disability with Disabled People's International, and I am working with CBR Asia Pacific Network. I am chairperson. I am working with CBR Global Network. I am working now in government also here in Pakistan, a subnational level, which is called Sindh province. Being a person with disability and activist with disability, we have always talked about the mainstream of the woman in disability and in other scenarios. When it comes to rehabilitation, in many countries, including Pakistan, situation is very poor because I have studied that in province where I am working, in one hospital at district level, there is only one therapist, that is physiotherapist. So it doesn't mean that could be man physiotherapist and that could be woman physiotherapist. So post is one, and if a man physiotherapist comes, he cannot take, he cannot provide service to women because of our culture and because of our religious interpretation. So in this way, women always left behind in one way or in other way. And when it comes to women with disabilities in rehab services, women double discriminated because first they are women being discriminated, and then they are women with disabilities, they again discriminated. So this is a main issue and recommendations which are given here. So I think from our perspective, we should invest more in rehabilitation workforce because once we have rehabilitation workforce and we will create posts in health system for this workforce, then people can access to these services. Because we have experienced that in Pakistan and especially where from I belong, people from remote areas goes for the services in the big cities like Karachi. So it is a problem. We don't find any human resource in the rehabilitative services. And when we think from gender perspective, then this issue becomes more complicated because women cannot get equal services like men. So this is a big issue. So what we need, that this rehabilitation should be in universal health coverage, and we are thinking that once in each hospital at district level, at taluka level, and at big small town level will not be available. Then this will be still outreach. Rehab services will be outreach from the women with disabilities. So what I recommend, I like the first recommendation, and this should be incorporated, and we can do more when we will work in this sector. So this recommendation can be implemented very well. Whenever it comes to the challenges, that we have a challenge that ownership, government don't take ownership for rehabilitation and for assistive devices. Even still now in Pakistan, assistive devices are not part of the health services. Assistive devices are provided only for the purpose of social security, charity, or philanthropy. So this is an issue. It should be included in the health system. Otherwise, still these assistive devices are outreach from the people with disabilities. And what about the stakeholders? In my part where I am living, we need stakeholders from the UN system, from the health public sector, from the disability. Means my department is Department of Empowerment of Person with Disabilities, from Women Development Department. So if these departments will not join the hands, then everybody will put these services on other persons or other departments' shoulders. A special role of in this regard is of WHO, and WHO can play important role to sensitize the governments and to develop such kind of task force or workforce among the government and among the NGOs, among the civil society, among the DPOs. So this type of workforce we can bring at the what I say at the provincial level, because in Pakistan we are living in the devolved system. So each province can decide about these segment of the societies. So it is my recommendation. We may think about that, and I think this will be beneficial for person with disabilities once we will have such services accessible for person with disabilities. Thank you very much.
Thank you so much. Thank you so much for that. Moving on to our next panelist, Lillian Asemwe. Lillian, please, over to you.
Thank you very much, Rosemary, for your earlier introduction. Today I am seated in a room, my son's room, next to a window. This is the most quiet place and less destructive. I'm wearing a forest green top with a root rash and a Devi pendant. Those of you from India and Pakistan and other Asian countries, you may relate. The rest I can tell you about this another day. I live in Kampala, which is about 30 kilometers. A place called Gayaza. It's 30 kilometers away from the city. Today, I want to speak about recommendation number 6, which is increasing collection and availability of evidence on sex and gender in rehabilitation. Fortunately, this recommendation comes in at the right time because the government has already rolled out a health management information system where data disaggregated by sex and gender is being collected. For example, the Ministry of Health TRIC, that is a template for rehabilitation information collection, will be used to carry out this task. We move on and look at why is this recommendation relevant in Uganda. Uganda has limited data on rehabilitation and assistive technology for decision making. For many years, rehabilitation data has not been collected in Uganda. Not until 2020, when a few variables were included in the health management information system. However, the information collected is mainly on the conditions seen by rehabilitation professions. On the other hand, Uganda Bureau of Statistics started collecting rehabilitation data that is disaggregated by sex and age. Thus, there is need to advocate for the collection of rehabilitation and assistive technology data that is gender sensitive, that is to say by sex, age, and others. We move on and ask ourselves, how can the recommendation be implemented effectively? This will be by working closely with the Ministry of Health, Division of Disability and Rehabilitation, and Division of Health Information System to ensure that sex and gender rehabilitation data variables are integrated into the existing health management information systems. Those are HMIS tools and other data systems such as the District Health Information System 2, the Integrated Human Resource Information System, and the Uganda Electronic Medical Records. The DHIS2, which has enabled improvement in timeliness of monthly health facility reporting, although there are still challenges of completeness of reporting, especially by the private health facilities, and data quality that requires monitoring and improvement. Ensuring there is adequate analysis, reporting, and linkages with decision makers, which will positively impact the available information systems for planning, performance review, and healthcare delivery improvement at all levels. Furthermore, there is an opportunity to work closely with the Uganda Bureau of Statistics to ensure that the 5-year demographic health surveys collect sex and gender rehabilitation data at population level. We move on and see which best practices can drive change. Implementation of the e-health strategy, for example, the recent health management information system reporting tools of 2020, they capture some disability-related indicators. This is according to the AT assessment report of 2020. Strengthening disaggregated data collection on rehabilitation, accessibility, utilization, and adherence by all. Establish and maintain information systems and database on the provision and utilization of AT, for example. Mapping of all service providers would support the drive to standardize AT devices, costs ensuring affordability by both men and women. I recently met an AT user with a hearing aid, but he only had one piece in the ear. On inquiring why he used one, he mentioned one was faulty and it's very expensive to replace or even to repair. Lastly, the improvement of data accuracy, quality, and reliability by conducting data quality reviews for verification. So with those discussed points, we see best practices being responsible for driving change. Thank you, Rosemary. Over to you.
Thank you, Lillian. Thank you so much for that. Sabina, over to you.
Thank you very much for your invitation. It's an honor to be here. As Rosemary mentioned in her kind introduction, my name is Sabina Chikone, and I'm working as Technical Unit Manager for Humanity and Inclusion Myanmar and Thailand program. So I don't know to what extent you are aware about the current context, so I want to give you a short background, because especially in Myanmar, the situation is dire, particularly after the events of the 1st of February last year, where the military took over the power after a landslide victory in the democratic general elections a few months before. This situation led to a massive protest of the civil population, and especially a civil disobedience movement that was led by medical personnel, doctors, nurses, and therapists, who became also a target when they were supporting injured protesters during the campaigns. And now, almost 1 year after these events, Myanmar has evolved into a protracted crisis. This whole situation, unfortunately, led also to the breakdown of the public health system, the economic system, the banking system, which of course bears a lot of protection and security issues, financial issues, and as we know, the women and girls are bearing a lot of this burden, especially when it comes to healthcare, since they are the main or perceived as the main persons taking care of the family, of the children, and the elderly. Since security is quite compromised, traveling is very difficult. It's a lot of protection issues. Services are closed, so they are not accessible, they are not available anymore, and it's quite a very difficult situation, since the situation actually is deteriorating rather than getting better. There are a lot of IDPs as well, where we don't really know where they are, a lot of movements, very difficult to reach them. So it's a very difficult situation. So under these circumstances, we consider meaningful participation as a very crucial issue, because we have to find alternatives to the public health system, since working with the de facto authorities is not possible for the moment. That is why it's very important to consult with people of all genders and persons with disability throughout all rehabilitation planning processes, accounting for diversities, intersectional factors, and spectrum of rehabilitation needs and severity. There is a specific focus also on survivors of landmines and IODs, since the number of casualties unfortunately increased again due to ongoing conflicts from before, and especially now also during this conflict that is going on for a year now after this coup situation. Therefore, it's very important to define participation to make it meaningful for the intended target group with the intended target group. So we also adjusted, of course, our activities, because we still want to reach the most vulnerable people, in this case, the main users of rehabilitation services, to recreate them, to use other sources. So we are working with OPDs, CSOs, and ethnic health organizations, and especially also mothers groups, women's groups, to really make that services for them as appropriate as possible. We established inclusive feedback and complaint mechanisms and analyzed this data on a constant basis to make sure that especially our target groups, so or amongst them, of course, women and girls with disabilities and users of services, to make sure that the channels we are offering are appropriate for them and they can actually articulate their needs, and that they can be reached, and our activities can be adjusted, especially in this volatile context, which is very important. as access remains a major issue. So there is a problem obtaining travel authorities, there are security issues, many women and girls don't feel safe to travel long distances or with the children. A lot of children are at home because of the security situation and the COVID situation, which deteriorated as well in line with the security issues. So so we work a lot through partners and with partners, and we established mobile units, comprehensive, who provide comprehensive services, so protection services, nursing services, MHPSS services, and rehabilitation services, closer to the communities and closer to the needs as a result of the needs encountered and expressed by our beneficiaries. And a close monitoring of the situation, of course, is ongoing to be able to really react to whatever is going on and to ensure that services, rehabilitation services, are still provided. Another issue that is important because of this COVID situation, importing assistive devices from abroad is very, very difficult. So we started to engage with local metal workshops, repair shops, etc., to see what kind of devices can be produced locally to have them available and to provide them to our beneficiaries. Thank you very much.
Great, thank you, Sabina, for that, for the context in Myanmar. We're now going to move on to the video from Gertrude Fefamame from the UN Committee for the Convention of the Rights of Persons with Disabilities. And while we do that, please do think of any questions you might like to ask our panelists today. Unfortunately, we don't have a lot of time for questions, but we would like to get to one or two of them. So please do type them in the chat box or the questions box right now, so we can go straight into them in the Q&A period. So please, over to Gertrude now.
Important is recommendation 2 on incorporate rehabilitation and assistive technologies in universal health coverage with attention to gender-related barriers. Governments have made a bold commitment, as we all know, to achieve universal health coverage by 2030. And also the Article 26 of the CRPD also acknowledges that rehabilitation is a human right and that state parties should take measures to protect and promote that all persons with disabilities can access quality rehabilitation. Without assistive technologies in this aspect, we will not achieve any of these. Why the recommendation is important. People with disabilities face many obstacles in their fight for equality. Now, although men and women with disabilities are subject to discrimination because of their disabilities, women and girls with disabilities are at a further disadvantage because of their combined discrimination based on gender and disability. So, social-cultural dimensions, poverty, high transportation cost, lack of education, and some factors that are those that impact on their access to rehabilitation and assistive technologies in health. Universal health coverage cannot be universal without noting the barriers to access and working to address them, and without appropriate assistive devices and the mechanism to ensure uptake by women and girls with disabilities, their access to healthcare will be very limited. For example, hard of hearing girl who requires a hearing aid in order to communicate adequately with the health personnel could be misunderstood and experience abuse through poor analysis and wrong medication. Women and girls with disabilities are empowered when they are able to access rehabilitation and assistive technology in healthcare and be on the same basis with others. In implementing this recommendation, financing rehabilitation and assistive technologies by government may also pose a challenge. This is because most states do not prioritize rehabilitation of women and girls in healthcare, and similarly, other stakeholders in healthcare may neglect the sector. So another example is that in some rehabilitation centers for persons with disabilities in Ghana, the percentage component of participation of women and girls with disabilities is less than that of men. First, obviously, the percentage investment and their requirements will be low. There is also lack of awareness by some women with disabilities, including girls, to uptake rehabilitation and ensuring that they have access to assistive technology. Turning this recommendation into reality by stakeholders. There is an urgent need for concerted global action to stakeholders to recognize the intersection discrimination of women and girls with disabilities. We want the phase and fully incorporate the gender dimensions in scaling up quality rehabilitation for women and girls with disabilities. 2, the need to expand financing for rehabilitation and assistive technology for all genders. Ensuring that quality health insurance schemes are established and women and girls with disabilities are benefited. 3, build capacity, raise awareness, and ensure the participation of persons with disabilities, particularly women and girls with disabilities, to uptake services in rehabilitation and assistive technologies in health. Thank you.
Great, thank you Gertrude for your words. So we only have time for probably about one question, and we do have a question related to data. And the question is really looking at, are estimates available for gender minorities in need of rehab and AT? And I know that in our fact sheet, we do say that this is a major gap, that the data is very, very sparse. It's a gap when we're looking at gender disaggregated data, looking for the needs of women and girls. So the question is for our panelists, and we'll open it up to maybe we can ask particularly Angela and Ghulam for their perspectives, being from where they're situated. How important is data for this work, for ensuring that we do meet the needs for those that are most marginalized? So Angela, maybe if we can start with you.
Thank you very much, Rosemary. As I emphasized in my submission, evidence-based planning and budgeting is very critical. And of course, without data and information, we cannot achieve evidence-based planning. So of course, in terms of planning and budgeting, we start with evidence. And that is why we really find that data is very, very critical. And of course, in terms of generation of data, it's always important to look at the individual needs of the users. Because if we don't, especially for those invisible disabilities, it becomes very, very challenging for us to plan in relation to meeting the needs of the users.
Great, thank you. And Ghulam, it would be great to get your perspective. How important do you think data is for meeting the needs of rehabilitation users, particularly those that are most marginalized?
Actually, in Pakistan, where we are situated, excuse me, so we have not a data of person with disabilities in our hands. Accurate question.
Oh, Ghulam, we're having a little bit of difficulty hearing you, so why don't we both take our videos off, and then if you could start your
We are not
response
covering
again.
question to cover with disabilities, how many people with disabilities are in Pakistan, and which kind of people with these are in which area, and rehabilitation services, and which kind of my video is there.
If you can turn your video off, we're having a little bit difficulty hearing you.
Hello.
Please start again.
I think now it is better.
Yes.
In Pakistan, country like Pakistan, we are still struggling for the data of person with disabilities, and we don't know which kind of person with disabilities are living in which area. We also don't know which kind of person with disabilities are receiving rehabilitative services. We also don't know which kind of person with disabilities need assistive devices. So this is a data kind of work is in very beginning phase in the Pakistan, and we have sensitized our Bureau of Statistics of Pakistan. They had collected 80,000 household survey only for person with disabilities, according to Washington question. So how can we reach on the rehabilitative services? This is far long way to go for us, and we are thinking now where we are approaching towards 2030 rehab conference. We need to start from now in Pakistan, and especially we are very eager where I am situated in Sindh province. We will support fully to collect the data, and we will cooperate with WHO in this regard. So I am inviting our WHO, UN Women, and other agencies to come here to create a good practice in the rehab with us and to have services. I think this will bring a real system devices. So I really good change for the countries like Pakistan and other countries where situation is like our country Pakistan. So this good practice could be replicated to the other countries. So I am very optimistic that if we will work together, which I talked in my presentation also, that we must have a workforce, and in devolved system we may choose one province and we may work there, and we identify our stakeholders who should be from the public sector, private, who should from and we succeed on the rehab. This way we will be, because in my part of the world we have a good legislation, not capacities to implement those legislations. Supposed to be we have a newborn screening act in our part of the province, and we have also another law, institute for rehabilitation
Ghulam, you are cutting off a little bit.
To develop workforce, but tech are very low in this part of, so
We do need to move on to our
So
wrap
I
up.
think it is a good opportunity now. If we will. A good time. Thank you. Okay. I have
Rosemary,
finished my talk.
shall I just add one point here about data? Yeah, thank you so much. Smitha here from India. I see that the data is also required to create community support systems, because everybody are using community support systems without their knowledge, like banks or education institutions or a police station, post office or a local market. Everything is a support system which is not being recognized. Whereas when it comes to persons with disabilities, it is seen as an additional or an exclusive support system, whereas it is just an extra bit of support which we need. And to create that kind of community support system, which is again our right as per the rights as per UNCRPD, we need data immensely. Thank you very much.
Thank you for that, and thank you, Ghulam, for your words as well. We do need to wrap up to our closing. The platform does shut off at 1/2 the hour, and we are a little bit over. So it is my pleasure and delight to hand it over to Maryam Mallick, who's a technical advisor at the World Health Organization in Pakistan, to offer a few closing remarks and a wrap up. So Maryam, over to you.
Thank you so much, Rosemary, and thank you USAID and RelabHS for organizing such an important webinar on such an important issue, which is rehabilitation through gender lens. And it was really a pleasure to listen to the speakers, to users, to the policymakers, decision makers. So we heard Smitha from India, and she talked about lack of gender responsive specialized services as compared to men with disabilities. And Mariana, she talked about her personal experience regarding when she contracted COVID. There were unavailability of medical and rehab services, which actually affected her her condition. And she also said that she wants a system where she can do everything wherever she wants to. We listened to Dake, and she had a very important cultural issue, which was that she needed to have a female technician for the provision of assistive technology. And Joy, she mentioned about accessibility issue, and especially lack of information, and that created hindrance in accessing the rehabilitation services and also assistive technology. So if you look at the global burden of disease study, which happened in 2019, and it was actually a much awaited baseline data on estimated rehabilitation needs, and it was published by WHO. So it mentioned that women accounted to just over half of the estimated 2.4 billion individuals with conditions that would benefit from rehabilitation and assistive technology. And if you look at the fact sheet also of RelabHS, it very clearly states that lower participation rates worsen rehabilitation outcomes, disproportionate burden of caregiving among women and girls when we talk about access to assistive technology and rehabilitation services. So I think when we really need to see how we can improve this gap or bridge this gap, one of the most important thing is that rehabilitation, it must become a political priority. If the demand for gender responsive rehabilitation, it needs to be increased. I can give you example of Pakistan. Maybe many of you have attended this very important webinar on assistive technology by 80 Scale. And it was the president of Pakistan who addressed the global community on improving access to assistive technology. And Pakistan has a leadership role globally, and it is all because that we have a very strong political leadership, a very committed leadership, which is like, actually leading this important aspect of assistive technology and how to improve access. So it really plays a part, when political leadership is also on board. And then rehabilitation governance, that is also very important. We really need to strengthen the rehabilitation governance, and especially from the gender perspective also. And it can be done through strengthening legislations, making policies, planning, establishing accountability and tracking progress mechanisms, by founding steering committees or technical work groups that can work together to set the strategic direction for rehabilitation policy and planning. And then methods for overseeing implementation of actions and establishing accountability. But we must ensure the gender equity acquiring key position within when we talk about having health governance bodies. And then our previous speakers, they also talk about integration of rehabilitation into the health system. A very, very important component, and especially when we talk about from a perspective of universal health coverage also. And successful integration into the into health system, when we talk about, it requires effective referral pathways, availability of the required workforce, resources, and including assistive technology. So WHO has launched the Rehabilitation in Health System Guide for Action, and I think it is an excellent roadmap for the countries to develop strategic plan to increase quality, accessibility, and effectiveness of rehabilitation and assistive technology. And then the previous speakers also talk about universal health coverage, of course, because it is a vehicle for making sure that everyone who needs rehabilitation receives high quality services to optimize and maintain their functioning in everyday life. And most important thing is without having or without suffering from financial hardships. WHO and Disease Priority Control Secretariat, DCP3, they have developed a universal health coverage benefit package that can be used as a key instrument for integration and monitoring of gender-related rehabilitation services, and also when we talk about access to assistive technology. Rehabilitation workforce. So we have less than 10 trained rehabilitation professionals for a population of 1 million in developing countries. It is a huge, huge gap. And we really need to ensure the availability of a multidisciplinary, gender-inclusive and gender-responsive rehabilitation workforce, ensuring rehabilitation as a topic which needs to be included in all workforce education efforts. Rehabilitation
Maryam,
workforce.
we do have a hard stop at 1:30, so if you can wrap up with your final words,
I'll just conclude by saying that it is not enough to know why people die and what illnesses they have. Perhaps what matters even more is to know how they live, to understand how health conditions play out in their day-to-day life. The vision of rehabilitation is equity, whereby everyone who needs rehabilitation receives quality services to optimize and maintain their functioning in everyday life. Thank you very much.
Thank you, Maryam. Those are excellent words to end this webinar on. So thank you for sharing those, and thank you everyone for joining us today. The webinar recording will be available on the RelabHS website, and again, thank you for taking the time to join us today and hearing about the need for gender responsive rehabilitation services.
Thank you. Bye.
Bye.
Bye, Rosemary.